Welcome, this is Dinah Miller. This is CPT coding for outpatient psychiatrists for the new codes for 2013. This episode is the second of a four-part series, and it's going to be on evaluation and management codes for dummies. It's not going to be a comprehensive guide in any way. It's just to give you an idea of how to begin coding and what are the things that you need to look at to determine what your codes will be. I'm going to recommend that you just listen without taking notes or getting too stressed out about it, because it's complicated and it will become clearer in the third and fourth episodes what is needed. It's going to be boring, and this is not authorized by any organization. The next few slides are reviews of information I've already given in the last episode, so I'm going to give you a little bit of time just to look at those, and then we'll get started. The next slide is a list of my disclaimers. This slide discusses my feelings about the AMA and APA deciding to move from rather clear-cut, simple coding to a very complex method of coding, and you're welcome to look up my article on Kevin MD. This is also a repeat slide, just letting you know that E&M coding is not easy or intuitive, and you will need some type of written resource in order to do this. For E&M coding, there are three different things that are looked at. One is the history, one is the exam, and one is the medical decision making. The history has four components: the chief complaint, which should be recorded for all visits, the history of present illness, the review of systems, and the past, family, and social history. And I'll tell you there should be a comma after past because it's past medical history. Each of the sections of the history has specific elements, and depending on how many elements you document, they are divided into degrees of complexity. Think of this as a Chinese menu that requires an Excel spreadsheet to order your lunch. After the chief complaint, the history of present illness is divided into 9 elements. The history of present illness is considered brief if there are 1 to 3 of these 9 elements described in bullet points, and the history of present illness is considered extended if there are at least 4 bullet point elements describing the current problem, or if there are 3 bullet points about chronic or inactive problems that are not part of those 9 elements of the history of present illness. I'll let you take a quick look at the elements. I'll note that location usually refers to location of pain, and in psychiatry it can be something like depression or hallucinations, and then you talk about the severity, the quality, the timing, things that modify or change it. The review of systems includes the review of 14 described body systems. I will let you take a look at these yourself. A problem-pertinent review of systems requires a review of just one system related to the chief complaint, and for psychiatry it's probably the review of the psychiatric system. An extended review of systems requires the review of 2 to 9 more systems, and a complete review of systems requires a review of 10 or more systems. You're allowed to get this information by having patients fill out forms or by having a staff member take it, but it must be reviewed by the physician, and failure to record the required number of review of systems elements is the most frequently cited deficiency in audits. The past, family, and/or social history is divided into 3 parts. The first part is the past medical and surgical history. This can also include things like medications. The second part is the family medical history, and the third part is social history. A pertinent exam includes review of one area related to the past family or social history. That's a typographical error where it says HPI. And a complete review of the past and social and family history involves one item for two areas if it's an established patient, and one item from all three areas if this is a new patient. The exam consists of three parts: the constitutional, the musculoskeletal, and the psychiatric. The components of the constitutional part of the psychiatric exam require measurement of any three of the following 7 vital signs, and they can be measured by somebody else. They include blood pressure in various positions, pulse rate and regularity, respiration, temperature, height and weight, and they also include general appearance of the patients, which a psychiatrist might put under the mental status exam, but it needs to be somewhere. So 3 of those 7 plus the general appearance for the constitutional components of the exam. The musculoskeletal exam includes assessment of muscle strength and tone and examination of gait and station. The psychiatric exam is a complete mental status exam. I will assume that I'm talking to an audience of psychiatrists and give you a few seconds just to look at the list. Okay, so we talked about what the level of the history was. Here I'm going to tell you how to figure out the level of the exam. And from all 3 elements of the exam, the constitutional, musculoskeletal, and psychiatric, the following number of bullet points must be documented to constitute each level of the exam. A problem-focused exam is 1 to 5 bullet point elements from all of those options of the exam. An expanded problem-focused exam is 6 or more. A detailed exam is 9 or more bullet points, and a complete exam includes all of the items on all 3 parts of the exam. Now remember, for the 7 listed vital signs, you only need to do 3 of those for the constitutional exam. The third component of deciding an evaluation and management code is the medical decision making. The process of making a diagnosis and making a treatment plan is tied to the presenting problem, which can be minimal, minor, low in severity, moderate in severity, or high in severity. Then there are 4 levels of diagnosis and management options, and there are 4 levels that depend on the amount and complexity of data that need to be reviewed and tests that need to be ordered. There's also a complex table of risks. Figuring out medical decision-making is not easy. It entails looking at a number of charts and criteria, and I'm not going to go in detail on that here, mainly because it was too complicated for me to figure out in a way to present easily. It does entail looking at these charts in order to do this. I'd like to let you know, however, that for seeing an established patient, except in an emergency room, you only need 2 of the 3 components to figure out a code. So you can have your history and exam and not consider medical decision making. For a new patient, in order to figure out the code, you do need to consider the medical decision making, which may be one more reason why you would want to use the simplified code for the psychiatric diagnostic evaluation rather than using an E&M code for a new patient. I will tell you that the Medicare reimbursement is probably higher if you use an E&M code, but it's also much more work and documentation. To decide the medical decision-making complexity, this is decided from the number of diagnoses and treatment options, the amount of data to be reviewed, and the risk of morbidity and mortality. Decision-making can be rated as straightforward, low, moderate, or high in complexity. You've listened to all this so that you could figure out the right code. And I'm going to tell you from all this information, it's these complex combinations, each with their own algorithms, that let you decide which code is permissible to use for either a new patient evaluation, if you do choose to use the E&M code, or for medical management of an established patient. In Part 3, I will discuss using the E&M codes for established patients. These are the codes that will replace 90862 psychopharmacologic management. And in Part 4, I will discuss how to use psychotherapy codes. Thank you for listening, and I hope this has helped.